Bismillahirrahmanirrahim. Surgical approaches, follow up, outcomes, and future developments in lung transplantation. Surgical approach for lung transplantation include the following: single lung, technically easier, technically easier, allows two recipients from one donor. Generally, now only used if interstitial lung disease, over distension of the compliant native lung and emphysema is uncommon but may be problematic. Bilateral sequential approach: worldwide more than 80% of lung transplants are now double. Sequential right and left single lung transplants at one time. Selective lung ventilation may under cardiopulmonary bypass unnecessary. Heart-lung approach indicated in Eisenmenger's syndrome or rarely in advanced lung disease with concurrent left ventricle dysfunction or coronary disease. Cor pulmonale is not in itself an indication as right ventricular hypertrophy resolves rapidly following lung transplantation alone. Living lobar transplantation: bilateral grafting of lower lobes from two living adult donors to replace lungs of a child or small adult appears to be safe for the donor with lung volume reduction of about 15%, but potential for 300% overall mortality, two donors and one recipient. Not widely performed in the United Kingdom. The follow-up after lung transplantation: patients are typically discharged from hospital about 1 month after transplant, following post-transplant bronchoscopy with bronchoalveolar lavage and biopsy. They will be followed up closely by their transplant center, but may also attend local respiratory clinics intermittently between transplant center visits. Be alert to possible complication and discuss with transplant center promptly if these are suspected. Spirometric values are generally very stable from 3 months after transplantation, as sustained falls more than or equal to 10 to 15% warrant further investigation. Remember drug interactions, particularly cyclosporin and tacrolimus. If new medications are added, check immunosuppressant drug blood level and medications and perform routine blood tests according to local transplant center policy. The routine surgery after lung transplantation: routine surgery more than 3 months after transplant can be carried out locally, but inform the transplant center. The morning dose of calcineurin inhibitor, cyclosporin, and tacrolimus should be omitted as there is a risk of nephrotoxicity with hypovolemia. Outcomes following lung transplantation: post registration outcomes at 1 year after listing for lung transplantation in the United Kingdom. 35% of patients are alive on list, 17 have died on list, 45% received transplant, 3% removed from list. At 5 years, 64% of patients transplanted and 25% have died on the list. Survival rates in the United Kingdom: 89% at 90 days, 80% 1 year, 57 5 years. Rate of death is highest in the first year, infection due to infection and primary graft failure. Risk factors for early deaths are pre-existing pulmonary hypertension, ventilator dependence, recipient ventilator dependence, and recipient age more than 50 years, donor age more than 50 years. Functional outcomes, lung function usually normalized after bilateral transplant and markedly improved following a single lung transplant. In COPD, FEV1 increased to 50 to 60 of predicted value after single lung transplant. Arterial oxygenation rapidly normalizes. 6-minute walk test distance typically doubles. Most patients active resume active lifestyle, although fewer than 40% of patients return to work. Limited data on quality of life. Initial improvement suggested, but effects after 1 year are unclear. 85% of survivors have no functional limitations after 5 years. Further developments. Future developments are likely to address both development of more effective treatments for chronic rejection, the new immunosuppressive drugs, and duration induction of immune tolerance, and the shortage of donor organs, e.g., living lobar transplantation, xenotransplantation, and further research in lung preservation. Vivo lung perfusion (EVLP) may increase the number of organs available for transplant. Ex vivo lung perfusion involves controlled perfusion and ventilation of the donor lungs for a number of hours in an attempt to improve the quality of donor organs previously unstable to make previously eligible organs suitable for transplantation. The bronchiolitis obliterans syndromes is the leading cause of late mortality after lung transplantation. Current research aims to increase understanding of its pathogenesis and develop novel biomarkers of early disease. The nature of interactions between the recipient and donor lung microbiomes is a subject of significant current interest and may be relevant to allograft tolerance and development of BOS, bronchiolitis obliterans syndrome. The complications of lung transplantation. The primary graft dysfunction, characterized by lung injury, include pulmonary infiltrates, hypoxemia, diffuse alveolar damage, organizing pneumonia on biopsy within first 72 hours after transplant. Clinical severity ranges from very mild acute lung injury to acute respiratory distress syndrome, presumably related to preservation and ischemia. Pre-perfusion injury exclude other causes, e.g., volume overload, pneumonia, hyperacute rejection, occlusion of venous anastomosis, aspiration. Treatment is supportive, that's to say, mechanical ventilation or ECMO. High mortality, 40 to 60 years. Acute cellular rejection. Acute cellular rejection is common and results from alloreactive T cell reacting to the donor HLA and other antigens. Acute cell rejection occurs particularly within 3 months of transplant and affects approximately 60% in the first year. It is rare after 12 pulses if adherence with medication is maintained, asymptomatic or may be associated with malaise, fever, dyspnea, cough, hypoxia, may present similarly to pneumonia or cryptogenic organizing pneumonia. A chest radiograph may be normal or show non-specific infiltrates. Common finding is fall in spirometry more than 10%, although this does not distinguish from other complications, particularly infection, ideally confirmed histologically. Transbronchial biopsy are safe and typically show perivascular lymphocytic infiltrates. Routine surveillance transbronchial biopsies can be used to detect acute rejection prior to falls in lung function. Treatment IV methylprednisolone pulses are given with the first 3 months of transplant. After this, high dose oral corticosteroids are used. The majority of patients respond quickly to augmented immunosuppression. Recurrent acute rejection is a risk factor for development of bronchiolitis obliterans syndrome. Acute rejection is an uncommon cause of breathlessness after 3 months, and other common causes of shortness of breath should be considered. Antibody mediated allograft rejection is increasing recognized and its optimal management is currently under treatment, may be attempted with IV immunoglobulin, plasmapheresis, or rituximab. Airway complications. Anastomotic stenosis, uh, most common and typically occurs weeks to months after transplant, suggested clinically by localized wheeze, recurrent pneumonia or suboptimal lung function. Treat with balloon dilatation, sometimes repeated, or stent placement via bronchoscopy. Complete dehiscence of bronchial anastomosis is now rare and requires immediate surgery or retransplantation. Partial dehiscence is managed conservatively, drain pneumothorax, reduce steroid dose. Infection, bacterial infection may occur early after first months after transplant or late associated with bronchiolitis obliterans syndrome, most commonly due to gram-negative organisms, particularly Pseudomonas aeruginosa. Recipients with cystic fibrosis are not at greater risk than other patients. An exception is beta-cepecia colonization, which is associated with a high risk of often fatal post-operative infections. Cytomegalovirus seronegative recipients from seropositive donors are at particular risk of severe infection, including pneumonitis. This is usually treated successfully with valganciclovir. Increase the risk of bacterial or fungal superinfection. Ganciclovir prophylaxis properly results in later, less severe infection. Cytomegalovirus infection appears to be a risk factor for development of bronchiolitis obliterans syndrome. Aspergillus Aspergillus frequently colonizes the airways after lung transplant, but clinically apparent infection develops in only a minority of patients. Peak disease incidence is at 2 months after transplant. Sites of disease include airways, and may lead to mucosal edema, ulceration in the pseudomembranes usually responds to itraconazole, voriconazole, or amphotericin B, fresh bronchial anastomosis, lung parenchyma, and disseminated aspergillosis associated with high mortality. Drug related complications. Immunosuppressive drugs must be taken lifelong following transplantation. Agents used include cyclosporin or tacrolimus, azathioprine or mycophenolate, both TFL and prednisolone. They are associated with many drug interactions and side effects, particularly nephrotoxicity and osteoporosis. Pulmonary toxicity is described secondary to sirolimus and everolimus. Cyclosporin, tacrolimus, and the sirolimus blood levels require close monitoring. The non-pulmonary complications, venous thromboembolism, and the cardiac arrhythmia are not uncommon following lung transplantation. Hypergam, hyperammonemia is a rare but serious early complication. Long-term complications include hypertension, renal impairment, hyperlipidemia, diabetes, stroke, and the potential ischemic heart disease. Remember also complications of the underlying disease as such as distal intestinal obstruction syndrome in patients with cystic fibrosis. The late complications of lung transplantations include chronic lung allograft dysfunction. Chronic lung allograft dysfunction represents chronic rejection and accounts for the relatively poor long-term prognosis following lung transplant. Two main types are now recognized: bronchiolitis obliterans syndrome (BOS) and restrictive allograft syndrome. Bronchiolitis obliterans syndrome is a form of delayed allograft dysfunction characterized by persistent FEV1 decline in the absence of other causes. May manifest histologically as bronchiolitis obliterans, a fibroproliferative process affecting small airways, sometimes with associated pulmonary vascular atherosclerosis. Histological confirmation is difficult. Transbronchial biopsy have a relatively low sensitivity, so a clinical diagnosis of bronchiolitis obliterans syndrome is defined in the absence of histological confirmation as an explained and sustained more than 3 weeks, fall in FEV1 in 2 or equal or below 80% of peak value post-transplant, uncommon in first 6 months, but prevalence subsequently increases steadily, affecting 50% of patients at 5 years. Malignancy. Increased risk of certain malignancies, such as lymphoma and other Epstein-Barr virus related post-transplant lymphoproliferative disease, skin, lip, vulval, and perineal carcinomas, in situ cervical cancer, and Kaposi sarcoma. Most lymphoma appear within the first year, and the lung allograft is the most common site of involvement with pulmonary nodules, plus or minus mediastinal lymphadenopathy. Lymphocyte aggregates from acute rejection may mimic the appearance of post-transplant lymphoproliferative disease on small transbronchial specimens. Lymphomas presenting after the first year are more commonly disseminated or intra-abdominal. Lung cancer occurs and may progress usually rapidly mimicking infection. Differential diagnosis of chest X-ray nodule following lung transplantation include post-lung lymphoproliferative disease or infection such as Pseudomonas, nocardia, Aspergillus disease, or mycobacteria, disease recurrence, and lung cancer.